Hey everyone. All right. So this is going to be the last week of schizophrenia and psychosis, and we're going to review and cover and wrap everything up. All right. So, psychosis. Can anyone recite to me the dopamine pathways? Anyone want to call them out? What is the pathway for positive symptoms of schizophrenia?
Mesolimbic
Very good.
is the psychosis.
Very good. So that's the VTA to the nucleus accumbens, right? What about negative symptoms?
Mesocortical,
Very good. And what's the connection of that? That's from what to what?
the ventrotegmental to the prefrontal cortex, and
Very
you have the dorsolateral and then the ventromedial.
Perfect, perfect, excellent. What about for movement disorders or any movement issues? What would that be called?
Nigrostriatal,
Very good. And it implicates what two parts? Very
the nigrostriatal and the basal ganglia,
good, excellent. And what about for prolactin elevations?
tuberoinfundibular
Perfect. And that would be what?
with prolactin.
Perfect, excellent. Wow, great. Okay. Sorry, guys, 1 second. The dog's out. Go, get out. Sorry about that. My wife is home.
That's
Okay.
okay.
So a patient comes to you and they're having their first episode of psychosis. They're very worried about weight gain and they're very worried about developing hyperprolactinemia. What would be a good first option for them and why?
Maybe Abilify.
Very good. Perfect. All right. And Abilify is classified as a what? What is it at the D2 receptor?
Partial agonist.
Perfect. Excellent. Now, why is it not affect prolactin? Because it's also a partial agonist in what pathway?
Tuberoinfundibular.
Perfect. Right. So in the presence of not enough dopamine, right? Abilify will work as an agonist in a way. It's going to give a little bit of dopamine, right? In the presence of too much dopamine, particularly in the mesolimbic pathway, it's going to work as a net antagonist. All right. So if someone has a lot of dopamine due to psychosis or delusions or whatever that it is, you give them a partial agonist, it's actually going to reduce the amount of dopamine that's being released, right? Because remember, only one molecule can bind to that postsynaptic receptor. So if you have Abilify bound there, the body's natural dopamine is not going to be able to bind to it. Does that make sense? Right? Now, if a medicine did not have higher affinity to dopamine, let me paraphrase. If a company was like, I'm going to make a medication and the affinity to dopamine is not more than the body's affinity to dopamine, you think that medicine would actually work? Why or why not? Would it work if its affinity to dopamine is not as strong as the body's
No.
endogenous dopamine? Yes or no?
No. No.
It's not, right? Because the body is just going to bounce it off. So in order to have an effective antipsychotic medication, you need to make a medication that the affinity for that med is going to be higher than the body's endogenous dopamine itself, right? If that makes sense. Now, the reason why I'm bringing that up is because there's also affinities based on medication. So, for instance, if someone is on risperidone, they're taking it daily, and you give them aripiprazole, the affinity for aripiprazole is actually going to be much higher, D2 receptor. So it's going to bounce off that dopamine. So, in essence, if someone is stable on risperidone and you give too much of Abilify, it's going to bounce it off, and the patient can have rebound psychosis. Has anyone ever seen that in the hospital? It can happen sometimes. So, if someone is on a strong D2 blocker and you give them a partial agonist, it's going to bounce it off. If someone is having elevated prolactin, but they're responding to a very strong D2 blocker, right? It would make sense to give them a partial agonist at low dose, but you don't want to go too high because it's going to bounce off and compete in the mesolimbic pathway, right? So in essence, if you want someone to be stable from psychosis and treat their hyperprolactinemia, you want to be able to give them a low dose of a partial agonist, and it's not going to interfere in the mesolimbic pathway, but it will interfere in the tuberoinfundibular pathway. Does that make sense?
Yes.
Okay. Another way, instead of giving someone a partial agonist, you can give them a medicine that's a very potent 5-HT2A antagonist. Now, what are some medications that are very potent 5-HT2A antagonists? Give me some. The what? The peen.
Beans.
Very good. The peen's perfect, right? But that comes at the expense of very strong anticholinergic antihistamines. So if it's anticholinergic, worsen constipation, blurred vision, dry mouth, right? By the way, is dry mouth a mild side effect? Yes or no? What do you think? Is it mild? Is it considered mild? Would you consider it mild if a patient says I have dry mouth? Would you say it's okay? Just drink water?
Yes.
Yeah. I've had patients lose their teeth because remember,
No.
your saliva can actually why do methamphetamine addicts lose their teeth, right? Because it dries up their secretions and their teeth start to fall out. So I've seen that with very patients on cogentin, olanzapine, their teeth can dry. So you have to tell them, hey, either stay hydrated and chew on sugarless gum so that you're getting your saliva to actually continue producing, right? Reduces cavities. So that's important.
Yeah, I meant yes, as in like just medicated and then keep taking the medication.
Oh, okay. No problem. No problem. Do not underestimate the power of anticholinergic. A lot of our medications are anticholinergic in psychiatry, like cogentin, hydroxyzine, and those meds can really make patients feel tired, groggy. They can look depressed. They can look very sedated, right? Do not diagnose someone with depression if they're on cogentin 3 times a day and on olanzapine twice a day, all right? What I would recommend is reduce the anticholinergic burden first, right? And then you can do a good screening for ADHD, right? Or whatever, or fatigue or depression, whatever that it is, right? It's good to understand what the neurotransmitters do because if a patient is having a symptom, you can link that together, right? It seems like you might be having symptoms of depression because you're on too much anticholinergic medications. No wonder you feel sedated. No wonder you feel like you're moving slow. Would it be okay to remove cogentin and see how you do? Believe it or not, EPS a lot of times is time dependent, which means that after being on a certain medication, your receptors will kind of adapt to it and you can re-challenge them off, right? So patients should not be on cogentin twice a day for years, right? You should try to challenge them off. I usually do, for me personally, I do it after 6 months and I try. 6 months in a year, I definitely challenge you off. Akathisia also, I don't keep you on beta blockers long term. I challenge it off. After about 6 months, I start lowering the propranolol, or I cut the mirtazapine in half, and then I stop it, and then I make sure your symptoms don't come back. All right. Don't keep patients on anticholinergic medications too long because obviously the mild cognitive impairment risks long term could also happen. I know it's kind of disputed, but patients on long-term anticholinergic, you don't want to worsen their cognition anyways. All right. Higher risk for falls, right? There's a lot of downstream effects for it. Any questions? Okay.
You said you challenged them even on propranolol?
Off. Yeah, if they've been
Even-
anticholinergic, I challenge them off of it. Only keep them on it short term, 6 months, then you challenge them off it. Because remember, it's their body adjusting to the dopamine blockade and nigrostriol pathway. What happens? Your receptors eventually will adapt to it, right? They'll start upregulating, they'll become more sensitive, right? Obviously, there's a risk of tardive dyskinesia, which actually, believe it or not, worsens with long-term anticholinergic medication. If someone has anticholinergic medications long-term, their tardive dyskinesia actually gets worse. So there's like a battle there. So even though their EPS gets better, their tardive gets worse. And if you give them a VMAT2 inhibitor, the opposite happens. Their dystonia or their Parkinsonism might get worse, but their tardive dyskinesia gets better. Get it? Because the mechanisms are different. One is a hypodopaminergic state, low dopamine, right? Which is dystonia, Parkinsonism, right? And one is a hyperdopaminergic state, which is tardive dyskinesia. I'm going to pause there for a second. Does that make sense?
Yes.
Now, another way to understand why to know the difference of the meds is because when you're doing switches, right? It's very rare when you're practicing, a patient comes to you and is not on any medications, especially if you're practicing in like areas which have a lot of chronically mentally ill patients. They're going to come to you on meds. You're going to say, hey, this med is not working. Can you please switch me? And I want to try something different. Let's say someone is on 20 milligrams of olanzapine and you wanted to switch them to Risperdal. How would you do it and why? Let's talk about it.
Would you decrease the dose of the olanzapine and start at a low dose of the risperidone?
Very good. So you tell me what dose. So I came to you. You want to do I say yes. I want to do the switch. What are you going to write me a script for?
Oh, the actual.
So I'm on 20 olanzapine now, and you want to switch me to Risperdal because I gained too much weight on olanzapine. I just don't like the anticholinergic antihistamine. I feel too sedated all the time. What dose of Risperidone would you prescribe me, and what would you reduce the olanzapine to?
I would think I would half the olanzapine, so maybe 10.
No, I would do 15. Do
Oh,
25%.
15. Okay.
Right? And start me on risperidone too. And there's going to be an overlap, right? That's called a cross titration. Now, there's risk and benefits for both, right? If a patient's very aggressive and there's a history of like hurting people or hurting themselves, I won't do a cross titration because remember, when you do a cross titration, one is going down and one is going up. In that middle, where it kind of looks like this, right? Because my elbow is the first med and my elbow here is going to be the second med. There's a cross titration going this way, right? This middle gap is going to be a risk of there being a subtherapeutic dose of the new med and a subtherapeutic dose of the old med, right? At that risk, there's a higher risk of you becoming psychotic and hurting somebody. So I wouldn't do a cross titration there. What would I do then?
Would you do like an LAI and then a PO dose of the new med?
No, because if you do LAI first, there's a risk of what if they're allergic to the LAI? I would always do oral before LAI. What I would do is I would give the equivalent dose of that med I want to get off. Like you can look on charts. So this is just estimating. Some charts are different, but if someone's on 20 milligrams of olanzapine, it's give or take, it's around 6 or 7 milligrams of Risperdal, right? Give or take. Some guidelines are different, but that's the average. I would give them the therapeutic dose of Risperdal and I would stop the olanzapine. But I would give something anticholinergic to help with the rebound that the Risperdal is not giving. Does that make sense? Sorry, everyone, I'm still a little sick today. Oh. So give the equivalent dose of the first med with the second med. Stop the first med right away. But if it's a peen, you want to give this something anticholinergic. Why? What would happen if I don't do that?
Rebound cholinergic effect?
Excellent. It would look like what? What's the
Like
opposite of anticholinergic?
excessive urination, like a lot of secretions.
Excellent. They would have diarrhea. They would probably be aggressive, right? Because the antihistamine is going to start wearing off. They're not going to sleep and they're going to feel miserable. So you need to give them something, whether it's a benzo, if they don't have any history of substance abuse, or a hydroxyzine, or even Benadryl. All right. And you would do the equivalent dose. I would probably do, I don't know, 100 milligrams of Benadryl and start tapering off that as we start getting them used to the lack of olanzapine. Do it in a month. It takes about a month for your cholinergic receptors to accommodate back to the way they were before. So I would probably do 100 milligrams of Benadryl, then 75 the next week, then 50, then 25, and then stop. Does that make sense?
So when would you stop, like let's just say on a Monday, when would you stop the olanzapine and start the risperidone?
Right away, following day. Once you pick up your prescription of risperidone, don't take the olanzapine that day. Just take risperidone.
Okay.
And the rationale behind that is because I don't want you to risk during that period of the cross titration having a subtherapeutic dose of antipsychotic. All right. Now, there's risks for that also. The risk for doing it that way is that there's a higher risk of EPS, right? Because you're going to have a therapeutic dose of Risperdal, and the olanzapine is going to have to wash out at the D2 receptor by itself. So in the nigrostriatal pathway, you're going to have a lot of dopamine blockade. There's going to be a higher risk of EPS. So what you can do is give them Benadryl. So to kill two birds with one stone. Obviously, it might sedate them, but it's better than nothing. It'll help them sleep. It'll help with the EPS that could happen from nigrostriatal blockade of both medications, right? And it also will help with the anticholinergic withdrawal. Does that make sense?
Yes.
Now, a tougher switch is when you're giving someone Abilify and you're switching off the olanzapine, which is rare. Why do you think I would do that? When would I switch someone off olanzapine to Abilify? If it's a what? A tolerability issue or efficacy issue?
Tolerability.
Yes, very good. Why? Explain to me. Why is it tolerability, not efficacy?
Because of the increased side effects from olanzapine.
Great, like weight gain, right? So this happens sometimes, right? Patients will come to you and I don't know, they were hospitalized, they were aggressive, they got into a fight with someone, so the hospital uses a lot of olanzapine. They put them on olanzapine right away. They had no previous trials of any partial agonists, and they don't need 80% of their dopamine blockade or 90% of their dopamine blockade, right? So in theory, they probably overshot it. It's like killing a fly with a hammer, right? You can kill a fly with a newspaper, but you wouldn't know that. The risk of killing a fly with a hammer is that you're going to damage your knee, right? Or hurt your body, killing it. Olanzapine might be too strong, too sedating, right? Um, Weight gain, metabolic issues. So you can trial them with an aripiprazole before. But if they've been on a partial agonist, let's say they've tried Vraylar, they tried brexpiprazole, I wouldn't do that switch, right? I'll probably switch them to Risperdal. Now I'm going to pause there for a second because this should make sense to you based on the treatment of the D2 receptor, right? Because a partial agonist is not going to be able to block dopamine the same way Risperdal does, or olanzapine does. Does that make sense? Is anyone confused by what I'm saying?
Can you just go over it one more time?
Yeah. So in order to treat someone typically with an antipsychotic, right, for psychosis, usually you need to block about 60 or 80% of the dopamine receptors, at least. But there are some patients that need 90% or 95% or even 100% of their D2 receptors blocked, right? So if someone is on olanzapine, they're getting, I don't know, 94% of their dopamine receptors blocked, right? The postsynaptic receptor. I'm just estimating. If you switch them to Abilify, at most, at 30 milligrams of Abilify, you can only block like 90% of the D2 receptors postsynaptically. It doesn't go higher than that. So it wouldn't make sense to switch them if they're not, if it's not if it's a pharmacodynamic issue, because they're going to be more psychotic. If the 94% of the olanzapine is not doing it, why would you put them on a less D2 blocking agent? Does that make sense? Assuming that they're a D2 responsive, right? There's also a possibility that's not going to happen. Then obviously clozapine would be the next best option. But just from a pragmatic standpoint, I would probably switch them to Risperdal and max it out and try to get more dopamine blockade. Even though Risperdal can cause weight gain, it's not as much as olanzapine, right? But what is the risk of Risperdal? It causes more what?
Prolactin?
Very good. Prolactin elevations. That's the only side effect. That makes it worse than the other meds. Now, I'm sure you see the dilemma that we have in psychiatry, right? We have a bunch of medications with very bad side effects. So it's kind of like pick your poison. Now, there are some patients that, they're fine with 60% of dopamine blockade and their psychosis is fine. They have antipsychotic benefit and they don't have any risk of EPS, right? Because that threshold is very high. If you have a low threshold, you need 80% of your D2 receptors blocked, and 80% D2 blockade in the nigrostriatal pathway also causes EPS for you, then you're one of those patients that, even though your symptoms are better, you're having side effects. Does it make sense to everybody? Because remember, the meds are affecting all the pathways, not just one. It's going to affect the mesolimbic, which you want, but it's also going to affect the tuberoinfundibular, the mesocortical, and the nigrostriatal pathway, right? Which causes side effects. I'm going to pause for a second so I don't lose anybody. Does that make sense to everyone so far? Okay. Now, if someone fails on two of those meds, right? Next step would be what? What would be the third step for treatment resistant?
Clozaril.
Clozapine?
Perfect. Excellent. I don't deem anyone treatment resistant unless I've actually done at least one trial of an LAI, right? Usually in Vega or Abilify Maintena at least. The reason why is because patients, they're not always taking medications the way they should be taking it, and they miss doses, obviously, because they have negative symptoms and they forget. So in order to make sure that I disqualify that risk of non-compliance, I make sure I at least put them on 1 or 2 months of long-acting injectables. Obviously, if it's not working and I do levels and they're metabolizing it appropriately, then of course I can rule out that it's not a pharmacokinetic or pharmacodynamic issue. No, I'm sorry, it's not a pharmacokinetic issue. It is a pharmacodynamic issue, right? Because the levels are showing that it's therapeutic. The patient is actually metabolizing it normally. And two, the long-acting injectable obviously is working because they're getting it, right? They're not refusing it, they're taking it. So then I would do clozapine, right? You're gonna start me on clozapine. What blood work would you draw first to make sure I'm a good candidate for clozapine? Huh,
CBC with diff.
perfect. Because you want to make sure ANC is normal, right? Before you start it. Now, what if my ANC has been abnormal, but it's been like that forever, and I'm from Africa? What would you do? What would you possibly diagnose and rule out? What is it called?
Oh,
Symptoms by age
Ben's?
level. Ben,
Is that
very good.
Ben?
It stands for benign ethnic neutropenia. All right, so you can do a genetic testing. I usually recommend them to go to PCB and they can do that. And sometimes you can do it clinically. Sometimes, like if you look at their past labs and they've always had low ANC and they've had no symptoms. But from a liability standpoint, just obviously you don't want to get sued for anything. Worst case scenario, just have a second set of eyes. I would have a primary care doctor document also they agree with you, and also if they can have a hematologist also do genetic testing just to rule it out. Right now, obviously, if they have Ben, then the parameters are different. They're actually able to stay on clozapine, even if their neutrophil count drops, but it can't drop below 500 nanograms per ml. If it goes below 500, then of course you have to stop it. But they're able to stay on it even if it drops below 1,000. All right. Questions? So benign ethnic neutropenia means that someone genetically, based on their environment, is just able to function with a very, very low neutrophil count and still not have infections. All right. Their body's used to it. Good question, Tom. Tom is asking, we need to block 60 to 80% of dopamine. What are the rough percentages of abilify, risperidone, clozapine? So it depends on the dosing. So technically, you could actually go super high on olanzapine and get almost 100% dopamine blockade also, and risperidone. The problem is, you go very high on the olanzapine, you're also going to go very high on antihistamine, anticholinergic. So if the patient gains weight and they're very sensitive, you'd rather get more dopamine blockade with risperidone or haldol than olanzapine. Does that make sense?
Yeah.
Because you don't want that extra. Not unless the patient is like, they're not eating, they have low appetite, they also suffer from insomnia, and their lipids are fine, then yes, maybe I would argue you can push up the olanzapine higher. All right. Now, there is some data to show that olanzapine above 30 milligrams works very similar to clozapine. That's why some people call it clozapine light. It does modulate glutamate at very high doses, above the FDA recommended dose of 20. So either 30 or higher, and I've done that too. 30 or 40 milligrams of olanzapine if a patient does not want clozapine, but I make sure I document that. So I make sure that Sorry, I make sure I document that I did counseling. I told the patient about the benefits of clozapine. They're aware that's for treatment-resistant schizophrenia, but they don't want to do blood work. They're afraid of all the other side effects, constipation, cialorrhea, all the other side effects of it. And I document it. And then I offer them olanzapine. All right? Questions? When will you draw a clozapine level?
1 week later?
Okay, you could. And what would you expect it to be? What would you look for?
Greater than 350?
Okay. And where would the cutoff be usually?
Oh, for the level, you mean?
Mhm. Some labs have 600, some have 700. So it really depends on the lab. The best thing
Okay.
to do is look at the patient clinically. If they're not having any side effects, they're not drooling, they're having bowel movements, you can keep it. It's okay.
Okay.
What do you do if a patient says they're drooling a lot? What would you offer me?
Atropine.
Very good. Atropine. So a locally acting anticholinergic medication, right? So you put drops under your tongue sublingually, and you swish and you spit. You can also use not, ipratropium sodium. I'm sorry, ipratropium sodium also under the tongue. What's the second option? Glycopyrrolate, very good, right? What are the risks of glycopyrrolate? It can make what worse? It's centrally and peripherally acting. So what do you think is going to happen? It's going to worsen constipation. That's why we usually keep it as second line. We don't do it first line. Now, what about, I'm afraid of weight gain. What would you start with me while you're starting the clozapine?
Metformin,
Very good. You would push it up to how high?
2 grams, start
Right.
at 500.
Okay. Now I say, Marie, you know what? The metformin's working, but I'm just feeling, I don't know, I'm feeling really depressed right now. I never felt this before. I don't know what's going on. What would you send me for labs for? What is metformin deplete?
By a folate and vitamin B.
B12 folate.
12.
Yeah, good. So you would check B12 folate.
Okay.
All right. So if someone's on chronic metformin, check B12 and folate. Excellent. All right. Clozapine has many uses, treatment-resistant depression. All right. Like I said, nephrogenic diabetes insipidus. Patients are very thirsty. They'll drink themselves to death for the most part. They'll keep drinking until they become hyponatremic, and then they can have a seizure. Right. If patients are very aggressive or have a history of aggression or chronic suicidality, clozapine and lithium are the only two meds in psychiatry that have evidence to help with suicidality. All right, so you should offer that to those patients. If someone has schizophrenia or psychosis and is chronically suicidal, I would offer them clozapine. Now, if a patient has low neutrophils, you also could, as a pro tip, I add low dose lithium also to kind of help keep their ANC above what it should be. So that's another option you can do also. The 300, 600 milligrams of lithium, what it does is lithium tricks your bones into thinking that it's a colony stimulating factor. So what it does is it makes your bones produce more WBC, right, red blood cells and platelets. So you can use that as a trick to keep the levels up if you can. All right, just know though that there is a rare side effect. It's a rare arrhythmia that lithium and clozapine can cause. So I would probably do EKGs like every 6 months with those patients, all right? Especially with patients that have other risk factors like, you know, hypo or hyperkalemia, any changes in calcium, any changes in sodium, right? Anything that can affect your chloride, anything that can affect your conduction of your heart, right? So any abnormalities in their electrolytes, I would do more frequent EKGs with that. Questions?
Oh, do you have to be careful with seizures and the combination of lithium and clozapine?
No, lithium does not lower the seizure threshold, so there wouldn't be a risk for that. But if someone's on a high dose of clozapine, right? If their levels start going, say if someone is not stable in 300 nanograms per ml of clozapine, you have to go to 500 or 600, very close to the top of it. They're at higher risk of seizure. So just monitor it, right? Sometimes you'll see monoclonic jerks. Sometimes patients will say they're zoning out, all right? Then at that point, you would probably rule out seizure activity. I would send them to neurologist just to rule it out. If someone's on clozapine and Wellbutrin, right? Risk for seizure goes much higher. Sorry. So I'm gonna get some water. Be right back. 1 second. Sorry, everyone. It's not a Heineken. This is a water. Now, if a patient is on clozapine and you try to increase the dose, but they have more side effects, their bowel movements start becoming less and less, they're gaining a lot of weight, what can you do to help supplement that? If someone still has residual positive symptoms, what could you add and why? A very potent what? And what blocker?
D2.
D2 blocker, right? You can use Haldol, you can use you know, Risperdal, you can do an injection. So there's no competition with D2 blockers and clozapine because clozapine does not work through D2 blockade for antipsychotic effect. Right? It's probably glutamate modulation, it's probably M1, M4 agonism, right? Other effects of it that we're not really sure about just yet. But so it doesn't compete. So you could add a strong D2 blocker there. If someone has negative symptoms, there is some evidence to show that adding a partial agonist like aripiprazole or Vraylar, I've done that myself with good effect, right? Now, what about if a patient is having some cognitive impairment similar to that? They have EKG issues, possibly prolongation might be a risk factor. They don't want to gain any more weight. What could be a good option to add to clozapine, which I've done also in the past? What's a medicine that doesn't really cause a lot of weight gain and neutral when it comes to QT prolongation?
Are we talking Latuda here?
Very good. Perfect. Excellent. Latuda. Great. Actually, I think Latuda is a very underrated medication in schizophrenia. It wasn't used a lot before because when it was branded, it was a pain in the ass to get it approved because you have to do a prior auth process, which took a long time. So now that it's generic, a lot of people are using it. They're actually finding it a lot more benefit too. So Latuda is a very good D2 blocker and it doesn't cause weight gain. So you can get very good D2 blockade and 5-Z2A antagonism without the risk of weight gain. The only side effect of Latuda is that obviously the 350 calories. If a patient can't get that much calories in, they don't get the full absorption of the medication, right? But it's a good medicine. You can push it up. I've had patients on 160 milligrams of Latuda and had no side effects. What's another benefit of Latuda? What serotonin receptor does it hit that helps with cognition? 5
HT7?
Perfect, 5-HT7, right? So there's not many meds that hit 5-HT7. Latuda is one of them. So that's vortioxetine is another one for depression. So what it does, it works on the GABA interneuron and it shuts off that GABA interneuron. So when you shut off GABA, it causes your receptors to freely release dopamine, norepinephrine, and serotonin. So you get like a trifecta effect.
Into your mesocortical pathway specifically, right?
Yes, mescal, perfect. Yep, mescal pathway. Now, what about I'm on a D2 blocker, right? And now I'm complaining about stiffness in my neck. I'm having what is that called when your neck is stuck in one way? What is that called? What is it called?
Torticollis?
Torticollis, right? Your neck is stuck. What would you give me? What would you offer me? Anticholinergic medication, right? Cogentin or Benadryl. If it's at night and the patient wants to sleep anyway, give them Benadryl. If it's in the daytime and you don't want them to fall asleep, give them Cogentin. All right. What about akathisia? How do you treat akathisia?
Atenolol, a beta blocker, or vitamin B?
Okay, vitamin B6, atenolol, beta blocker. What's another one? It's an antidepressant. It's part of California Rocket Fuel.
Oh, mirtazapine?
Very good. Perfect. Mirtazapine, right? Assuming the patient does not have what? Comorbidity.
Mania.
Yep. Or bipolar. Right? Yeah, because it can worsen that. Excellent. Okay. See, you guys are sharp. Look at that. Okay. What about tardive dyskinesia? We're going to talk about that today, right? So what are the class of medications that we use to treat tardive dyskinesia?
VMAT2 inhibitors.
VMAT2 inhibitors. Very good. All right. So how does VMAT2 work? So VMAT technically it helps with recycling of your neurotransmitters, right? So whatever does not go inside the VMAT, right, isn't saved. So what happens is there's a vesicle there called the VMAT. Whatever goes inside of it is recycled. If it doesn't go inside, catechol-methyltransferase, monoamine oxidase will eat it up, right? So in essence, it's going to reduce the amount of that neurotransmitter. So in the nigrostriatal pathway, over time, when you block D2 there, your receptors are going to what? They're going to
Upregulate.
become more sensitive, right? So in essence, it's going to be a hypodopaminergic state there, which is going to cause a lot of spastic movements, a lot of like rhythmic movement of your shoulders, of your trunk, of your face, of your mouth, of your tongue, right? That's because it's a hyper increased dopaminergic state. So one way to do that. Now, the interesting thing about tardive dyskinesia is before we had VMAT2 inhibitors, one of the strategies that providers should do is they would just increase the amount of dopamine, right? So dopamine blockade. So if someone was on Haldol 10 and they had tardive dyskinesia, you give them Haldol 15 and what? It goes away. Why? Because it's going to block all those upregulated receptors, right? But what's going to happen eventually is your body will create more receptors and becomes more sensitive. And you can't go to Haldol 100, right? Because you're going to make the patient toxic. So it's eventually going to have to be modulated another way. So yes, temporarily you can give someone a higher dose of their med and the tardive dyskinesia will get better. But over time, the same thing's going to happen again. So you have to treat it eventually, right? Another option of treating tardive dyskinesia is patients would get switched to clozapine because clozapine, doesn't work on D2 blockade. But the problem is if you unmask the D2 receptors, right, and give clozapine, which doesn't block D2 receptors, you can get much worse tardive dyskinesia because you're unmasking now all of those postsynaptic D2 receptors in the nigrostriatal pathway, and they're upregulated and they're more sensitive. That's why when patients stop meds, very strong D2 blockers, they actually get tardive dyskinesia. It's called rebound tardive dyskinesia. Then they go back on the meds and it actually goes away. Has anyone seen that before? A patient stops their psych meds for a couple of days and they have tardive-like movements. Then they go back on it and it goes away. That's actually not tardive dyskinesia, by the way. That's called withdrawal dyskinesia. It's different.
So it's self-limiting, right?
Yes, self-limiting. The same thing happens in the mesolimbic pathway. What happens if someone stops their very strong D2 blocker without tapering off? What happens?
Rebound psychosis?
Rebound psychosis, right? Very good. Now, how does VMAT2 inhibitors work? What they do is they block the VMAT, so it stops the reuptake of those neurotransmitters, right? So when you stop the reuptake, all those neurotransmitters are going to get eaten up by monoamine oxidase and COMT. And in essence, you're going to remove the amount of dopamine, and of course, symptoms get better. Does that make sense?
Yes.
But what happens after that? When you start depleting all the dopamine, what side effects could the patient have after that? What do you think?
Parkinsonian symptoms.
Very good. That's why sometimes you have to put patients on both a subtherapeutic dose, or I wouldn't say subtherapeutic dose, but a low dose of cogentin and a low dose of VMAT2 inhibitor. You have to try to find that balance. Sometimes you can find it, sometimes you can't, and you have to ask the patient what's worse, the tardive dyskinesia or the Parkinsonism or the dystonia, and you have to pick because you can't get both better. I know it sucks for a patient. It's horrible to have to decide, but unfortunately, that's the best we can do right now.
What if they say they don't know and they really want you to decide and both look pretty bad? Like, how would you go about thinking about that?
I don't know. It's tough. I mean, they both have the risks, right?
Now, with that, is the tardive dyskinesia irreversible? So would you not want to,
Yes, tardive could be reversible if you catch it early, but if it persists for a long time, it's irreversible. Yeah.
but if the person comes to you and says, "Oh, I prefer the tardive," would you suggest that they don't because that's irreversible long term, whereas Parkinsonian maybe wouldn't be?
Well, even though Parkinsonism is not permanent, they're going to be on D2 blockers probably lifelong, right? So even though they're still going to have it lifelong, that makes sense? Because they're still going to be on the injection or the antipsychotic medication. Because if you try to lower the antipsychotic med, they become psychotic. So what options do you have? So I get what you're saying, Marie. It does make logical sense to me, but if they're going to stay on this dose of Risperdal Consta or Invega Sustenna, they're probably going to have EPS anyway because that their body already dictates. I need 95% of my dopamine blocked in order to have not have symptoms, right? But at the same time, that blockade also causes me to have dystonia or other signs of Parkinsonism. So it would be quote unquote lifelong if I'm going to be in treatment with schizophrenia lifelong.
Have you ever experienced this before?
Yeah, I've had a few patients where we had to choose. Yeah.
Do you choose or do you do like the
I
art
have the
of
family.
cycle
I
5?
don't want to make the choice for them. We kind of talk about it with the family and they decide, you know. I've
No,
had
but do I
patients
mean,
choose one over the other. It's gone both ways.
so you have to choose, you can't do like 6 months of one, 6 months of the other so that you balance between the two?
Uh, I mean, I guess you could try, but I've never had a patient ask for that. We just kind of stay on one. Yeah. I always make a joke with the reps when the VMAT2 inhibitor reps used to come to the office, and they're like, "How would the patients like it?" Well, I just had one patient. The wife was like, "He was such a passionate kisser, but now he doesn't really kiss as good anymore since we gave him the VMAT2 inhibitor." And the joke is that obviously the movement of your tongue is not going to be as prominent once you get that VMAT2 inhibitor. But yeah, it sucks because eventually what's going to happen is you're going to have higher risk of your joints are going to start hurting more, right? Imagine always moving your shoulders or moving your hips constantly. Obviously, you're going to have higher risk of osteoporosis, all the risks of moving your joints constantly. So, but also there's a risk of Parkinsonism. You can have laryngeal spasm and choke on your food and die. So again, it's not an easy choice.
Are there any non-farm like protective mechanisms you recommend to people? Like, I don't know, or maybe supplements that you recommend people to protect themselves from tardives or
I'm not
Parkinsonian?
aware of any supplements that have been studied to show to reduce that. I will tell you there are risk factors of patients developing tardive dyskinesia, though. One risk factor is cocaine abuse. If
Huh?
someone is using cocaine, right, they have a higher risk of developing tardive dyskinesia if they become psychotic and they have to be on antipsychotic medication because their the pathways are already, dysregulated from the cocaine or methamphetamine use. Another one is if you develop dystonia early, when you first take an antipsychotic, you're at higher risk of developing tardive later on, the longer that you're on it. So let's say the patient that's treatment naive and gets put on a low dose of Risperdal and they develop dystonia, even though it's low dose, they're going to be at higher risk of developing tardive dyskinesia as they get older. So those are two risk factors that I'm aware of, but other than that, I'm not sure of any other ones.
So that would imply that best practice is probably starting off with a second generation or a less D2 blocking
Yeah, I
agent.
guess. I guess based on risk, right? So if a patient's not aggressive and, I guess you can monitor the metabolics pretty well, then I guess second generation would be a fair option. Now, I don't like looking at first generation, second generation because I think it's bullshit because there's some first generations that are very antihistamine, anticholinergic anyway. But there are meds that are, remember, I was talking about affinity, right? Or potency, affinity or potency. You have high potency medications, right, at the D2 receptor, which you give very low dose, like Haldol 1, and get a very good blockade of dopamine, right? And you have a low potency, which you need to give much higher doses, like quetiapine. Like you need, I don't know, 600 milligrams, 700 milligrams to get a decent blockade of dopamine at the post receptor. And you also have middle, middle potency doses, like perfenazine or stelazine. These meds are they're like middle potency. You can give like 10 milligrams of the med or 15 milligrams of the med, and it doesn't hit dopamine. It has a little bit of antihistamine, anticholinergic. So in theory, you might mitigate some of the metabolics and some of the EPS. But again, it's hard to find those meds because they don't really make those anymore. They're very old school meds. I've only seen a few patients on them. So perfenazine is one and stelazine is another. But you're probably not going to see them anymore. I'm sorry, another one, loxapine, a third one, is also middle. The reason why loxapine is still used is because it was actually synthesized as a from clozapine. So they kind of tweaked the molecule of clozapine a little bit, and they thought that they could make a clozapine-like med without causing neutropenia. But unfortunately, it wasn't as potent. Treatment-resistant patients were not responding as well to it. But loxapine could still be used because it might give some of those properties, and also it comes in inhalant. It's one of the only antipsychotics that comes in inhalant, which I've never seen used before, but hey, it's another option for a patient. They don't want injections, they don't want pills, they can inhale it. Questions? So know that the VMAT2 inhibitors, there's valbenazine and there's deutetrabenazine, right? There's valbenazine and deutetrabenazine. Those are the two. I forget the brand names of them, but they compete with each other. Don't worry, I'm not going to ask you about the branded. Just know that they work as VMAT2 inhibitors and understand that VMAT2 reduces dopamine release in the nigrostriatal pathway. All right.
Ingresa?
Ingrezza is that yeah. Is that due to deutetrabenazine or is that valbenazine? I always forget.
I know it's one of them. I forget.
Yeah. Guess how much they cost a month?
1,000.
Higher. But $25,000 for a monthly supply. Imagine that. So imagine if you didn't have insurance, you had to pay 25,000 cash a month for that medication. And it's only branded, there's no generic. So that's why it's very difficult to get it. I had a patient that was going to school in the Philippines and he was stable on it and he had tardive dyskinesia. I begged the rep, I'm like, please, he's coming back in a year. He's just here to finish college. I said, can you please give me like a year supply of it? And he gave me a year supply and I told the patient, I'm like, listen, don't put this in your carry-on because if you lose it, you're not getting another one. Imagine what's 12 times 25,000? It's a lot of money. You could buy a house in South Carolina. So the meds are very expensive. And they usually only give you two samples. They won't give you more than that because it's so expensive. Questions? Clozapine risk. Very potent CYP1A2 inhibitors. All right. Make sure you screen for caffeine use. If you drink too much, more than 4 or 5 cups of coffee a day, it could significantly increase 1A2. The clozapine, I'm sorry, decrease 1A2 and increase levels of clozapine. Sorry. If they smoke cigarettes, it's going to increase 1A2, reduce clozapine. All right. So caffeine, what's going to happen? Caffeine is going to raise clozapine levels because it's going to inhibit 1A2. It's not going to be broken down. All right. They smoke cigarettes, it's going to increase 1A2, the enzyme, so clozapine is going to get broken down faster and the clozapine levels are going to drop. All right. Other significant interactions with clozapine is antifungal medications. They could increase clozapine levels, right? Even topical. If someone keeps taking topical antifungals, they don't know that it's only short term. It could, in theory, leak into the bloodstream and increase clozapine levels also. All right. Obviously, oral is going to increase it. Ciprofloxacin is also going to increase clozapine levels. All right. HIV medication, antiretroviral medications could also inhibit. It's not going to inhibit 1A2, but it's going to inhibit 3A4, which is partially metabolized clozapine also. So it could make it. If someone's clozapine level is like 700, obviously adding any other meds that are 3 or 4 inhibitors could increase it a little bit. All right. Chamomile tea also, like I said, also inhibits 3 or 4, so it could increase clozapine a little bit. So clozapine is majority 1A2, but it's also partially metabolized by 3A4, so there could be interactions there. All right. Questions? Anything not clear? Fluvoxamine for OCD is also a very potent 1A2 inhibitor. Could also increase clozapine levels. Questions? When would you use Haldol-Deck with a patient?
I apologize. What's the question?
When would you use Haldol-Deck with a patient?
When they need more D2 blockade?
But you can get that with a Invega Sustenna.
When they can't tolerate anticholinergic effects? When they just need like a straight D2 blocker?
Good. Yeah. So that could be, yeah, you don't want any other dirty effects, right? You don't need anticholinergic, you don't need antihistamine, you don't need any of the other stuff. So therefore you can give that to them, right? Plus it's cheaper, right? And it's easier to get if the patient has to have insurance. It's cheaper. What should you assess for before giving Haldol-Deck? Allergies to what?
Sesame oil or egg whites?
I didn't know about egg whites. Is egg whites involved in that too? I know sesame oil for sure. Is there egg whites in the solution?
I'm wrong about the egg whites. I'm
Are
probably
you?
wrong. I think so. Yeah, let me double check, but I think so.
Okay. I think it's just sesame oil. So I'm not going to test you guys on switching, but the reason why I used the example today because it was a good way to kind of, make the mechanisms make sense and how you switch from what based on their mechanisms, all right? So catatonia, we'll talk about that. So catatonia, what is the treatment for catatonia?
Benzodiazepines.
Very good. Which one particularly?
Ativan.
Yeah.
Diazepam challenge. Very good. Excellent. All right. So you would give them an IM, see what dose of IM gets them through the day that gets them fully functioning. All right. Then whatever that dose is, you're gonna when you discharge them, you're gonna keep them at that dose for at least a year and reduce the dose very slowly so they don't relapse. I think I told you guys I had a few patients that had catatonia, they had to stay on a low dose Ativan and they've been on it for years. And every time I try to get them off, the catatonia comes back. So we just keep them on. So catatonia, panic disorders, those are probably two of the most common reasons to keep someone on long-term benzos. All right, any questions about antipsychotics or anything? I'm sorry, guys, I'm still not feeling well today, but anything that's not clear, anything I need to review again? Oh, we didn't talk about Cobenfy. We didn't talk about Cobenfy. Did we ever talk about it? Xanomeline trospium?
No, we didn't talk about it.
I think I should talk about it. So there's a new treatment for schizophrenia, which was FDA approved about a year ago. So I'm a consultant for them and I speak for them. I just want to be transparent. So, I am paid by them for doing talks about it. Not for this one, obviously, but I do talks about it. So the interesting about Cobenfy is it's a cholinergic agonist and an anticholinergic medication at the same time, right? So, you're probably going to wonder, why am I giving conflicting mechanisms there? Because the xanomeline, which is a cholinergic agonist, actually only works centrally. So it works in the M1, M4 receptors in the brain, right? Now, the problem is if you give someone xanomeline, they can have cholinergic side effects peripherally because it affects the brain and affects the body. So they'll have diarrhea, like drooling, all the side effects of M1, M4 agonism peripherally, right? So the farm company they were smart enough to find a molecule that pairs very nicely with it that only works peripherally. So trospium only works peripherally, right? Only works on the peripheral system, so it doesn't affect the brain. Because if it was affecting the brain, it would counteract the antipsychotic effect of the xanomeline. So you have a med that has a centrally acting M1, M4 agonism, right, and peripherally acting, but you don't need the peripheral, and it's being blocked by the anticholinergic trospium, which is only working peripherally. All right. Now, the reason why M1, M4 works as an antipsychotic because there are connections, interneurons of acetylcholine that connect directly to the ventral tegmental area. And what happens is if acetylcholine binds to the VTA, it tells the VTA to secrete dopamine, right? So in someone who has psychosis, there could be a hyperfiring of acetylcholine in that pathway telling the VTA to secrete dopamine, right? So yes, in theory, you could give them a D2 blocker, right? But that's more downstream. If you go upstream, what if the reason why they have too much dopamine is due to that interneuron, which is acetylcholine interneuron? So another way is you give them an M4 agonist, which actually is a autoreceptor on that acetylcholine neuron, right? So that acetylcholine neuron is hitting the VTA, right? The VTA is hitting my elbow, which is nucleus accumbens in the mesolimbic pathway, right? So this acetylcholine neuron has M4 autoreceptors on it. If you give them a molecule that's an M4 receptor agonist, it's going to shut down the release of acetylcholine, therefore shut down innervation of the VTA and have an antipsychotic effect. Does that make sense? Now they tried to actually also get dual indication as an adjunct, but for whatever reason it failed. The trials never separated from placebo. So what they did was they did a second trial, an extension trial, where they were adding Cobenfy to Risperdal to Abilify, all antipsychotics except very strong anticholinergic meds, right? Obviously, no clozapine, no quetiapine, no olanzapine, because that would compete in the cholinergic pathways, because they're anticholinergic meds. It didn't separate from placebo, so it failed. So unfortunately, they didn't get that second indication, which I was shocked. I actually thought they were because I knew my colleagues were using it already adjunct with good benefit, and patients were saying they were feeling better. But remember, sometimes just the patient population, the way they do the study, it doesn't always reflect what you see in clinical practice. So I do have colleagues that still use it as an adjunct, and the patients do fine. Like patients who have negative symptoms or patients who can't tolerate too much dopamine blockade because of risk of EPS, they add Cobenfy as an adjunct. Obviously, it would be considered off-label because it doesn't have an indication. Questions, thoughts?
What do your colleagues usually prescribe it as an adjunct to?
Risperdal, Abilify, anything that's not very strongly anticholinergic, right? No quetiapine, no clozapine, and no olanzapine.
But why the Risperdal if it's already a D2 blocker? Oh, because Cobenfy
Because if
does
you
it.
go too high, it could cause EPS.
I see.
So you can get away with doing a low dose of Risperdal and adding Cobenfy. So three ways right now that we have to help modulate psychosis is obviously D2 blockade, right? That's one. Clozapine to glutamate modulation. That's two. Three, 5-HT2A antagonism, specifically in Parkinson's psychosis, using Nuplazid or pimavanserin, right? It's the same medication. Nuplazid is the brand name, pimavanserin is the generic name. And obviously, Cobenfy, xanomeline trospium, M1, M4 agonism. All right, those are the four mechanisms that we have. Questions? Anyone confused? Please ask. In theory, for very treatment-resistant patients, I've also added very high dose olanzapine and Risperdal together. It wouldn't make sense to give therapeutic dose of olanzapine 20 milligrams and let's say 5 milligrams of Risperdal, right? Because at that dose, olanzapine is just a 5-HT2A antagonist and a D2 blocker, right? But like I told you guys before, if I go 30 or 40 milligrams, it changes it. It modulates glutamate more, so therefore I could use the two mechanisms, D2 blockade and glutamate modulation with those patients that don't respond. Obviously, clozapine would be the first choice, but they don't want clozapine, so that would be my second choice. Now, Abilify has a very strong half-life, right? And olanzapine is a short half-life. So sometimes if someone is on Abilify, they've been on it for a while, it's going to be very hard to add another antipsychotic because the Abilify is going to be on board, right? Does that make sense? Because Abilify has high affinity, right? That's one. And two, it has a very long half-life. So even if my last dose of Abilify 30 milligrams was yesterday, and you give me olanzapine now, most likely the Abilify is still going to win at the D2 receptor in the mesolimbic pathway. Does that make sense? So I might not see the effect of the olanzapine until maybe 2 or 3 weeks after, because I have to wait for that Abilify to wash out first, which could be a challenging switch. Does that make sense to everybody? Or is it not clear? Now, sometimes if a patient is aggressive inpatient, you would have to give them a benzo just to calm them down because you know you're not going to be able to override that Abilify in the mesolimbic pathway. It's too strong of a molecule. The affinity is way too high. If you guys are bored later and you can't go to sleep, go on Wikipedia and look up Ki value of Abilify, look up Ki value of Risperdal, look up Ki value of olanzapine, and see which one is lower. The lower one actually has a higher binding affinity. I think Abilify is like 0.00 or something. It's less than one. Now, I know we're talking about schizophrenia now, but obviously for the final, everything's going to be cumulative. And I want you guys to know this too. If you're going to use Abilify as an adjunct, let's say someone's on Prozac and Buspar TID, right, as an adjunct for depression, and you want to use Abilify as an adjunct, please stop the Buspar. Don't keep them on Buspar and Abilify at the same time. Why? You're giving them the same mechanisms twice. It's polypharmacy. What is it?
5-HT1A partial
Very
agonism.
good. Exactly. They don't need to take the Buspar anymore. You're getting 5-HT1A from the Abilify. I've seen that too many times and it pisses me off because it's a waste for the patient to take the boost bar. It doesn't do anything anymore. And there's a lot of meds that have 5-HT1A, so you can easily stop boost bar. Mirtazapine, trazodone, any of the partial agonists, the Abilify, brexpiprazole, cariprazine. A lot of those meds, vilazodone has 5-HT1A in it. Vortioxetine has 5-HT1A in it. Olanzapine has 5-HT1A in it, right? So there's a lot of meds that have 5-HT1A. You can easily stop the boost bar and not keep it on. I think boost bar is probably one of the most used meds that are polypharmacy that don't need to be there. Because there's a lot of other meds in psychiatry that already have 5-HT1A partial agonists. Doesn't mean not to use boost bar, because if someone does need 5-HT1A, they don't need D2 blockade. Boost bar's fine. That's all you need. It's 5-HT1A partial agonism. It works. But if someone's already getting something else that has 5-HT1A, stop the boost bar. There's no reason for it. Any questions? This is the last lecture for schizophrenia, so please, if you have anything that's not clear, let me clarify it now.
Clozapine has muscarinic activity too, right? That's also part of its antipsychotic effect.
Yes.
Can you speak about that more a little bit, like especially as it compares to Cobenfy? Like, do they have higher? Should we even think about their affinity toward M receptors, or is that only a dopamine receptor thing? You know what I mean?
Sorry. So say it again.
Like when we think about the M4, M1 receptor affinities of clozapine and Cobenfy, we don't. I noticed that the books nor you guys don't really talk about the affinity profiles of them. Like we're only thinking about the affinity profiles toward D2, right?
Yeah, because right now, since it's a new mechanism, they haven't really done many trials on it, so there's not a lot of data on it. But I can ask, because I mean, say speak for them, I can always ask for the data. So what I'll do is next time I go to the meetings, I'll ask them if they have any data on that, on the M1, M4 affinities, and I'll get back to you.
Thanks.
The interesting thing about the company that had Cobenfy, it used to be called CarXT. It was Karuna, Karuna. It was a very small company, maybe like, I don't know, 30 people, 40 people there. When it got bought by Bristol Myers because they realized it could be a groundbreaking medication, the stock went crazy. They were saying that almost everyone from Karuna, the original company, they actually retired. They're all rich millionaires. Only a handful of people actually stayed, and that's because they really believe in the drug. So it's amazing. Imagine having your company bought out, right? You're automatically a millionaire, and you're still working because you believe in the product. So to me, that's very it's very inspiring. Because we do need better treatments. Unfortunately, right now, the paradigm is just D2 blockade, but I think eventually we're going to move away from that. There's just too many neurological side effects. Tardive dyskinesia, Parkinsonism, quality of life of patients are very bad. Tardive also, when your teeth are grinding, your teeth fall out. So again, it's quality of life issue. So if a patient complains about something, make sure you address it because long term, it's going to be bad for them. So we're always trying to find a balance between treating symptoms and making sure that patients don't have any worse side effects long term. Weight gain is another one, creeps up on you. And also, no, there are some case reports of patients developing diabetic ketoacidosis on olanzapine. You can look it up. So just be aware that if a patient takes olanzapine and they start having symptoms of DKA, it can happen. So there's case reports of it. Like very quickly, like rapidly, within days. Any questions?